All right, let's get right into it. We are talking about increased intracranial pressure, or ICP. And listen, this isn't just some random topic for your nursing exams. This is a full-blown, life-threatening emergency where every single second counts. So if you want to keep your patients safe and nail that NCLEX question, you have got to know this stuff inside and out. So here's our game plan. We're going to start with what ICP actually is, using a little analogy I call the cranial pressure cooker. Then we'll decode the warning signs you absolutely cannot afford to miss. We'll talk about the race against time when those late, deadly signs appear. Then we'll cover the nursing playbook, what you actually do, and finally, the go-to medications for treating the pressure. Okay, first things first, what is really going on inside someone's head when they have ICP? The best way to picture this is to think of the skull as a pressure cooker. Seriously. It's a hard, bony box that can't expand. So when anything inside, brain, blood, or fluid, starts to swell, that pressure has nowhere to go but up. Up, up, up. So in clinical terms, ICP is just that. Way too much pressure inside the skull, squeezing the life out of the brain. Now here are the numbers you need to burn into your memory. Normal ICP is between 5 and 15 millimeters of mercury. The moment we start creeping above 15, we are officially in the danger zone. So why is this pressure so dangerous? What's the end game here? It all comes down to one thing, that pressure eventually squashes the brainstem. And you know, the brainstem is our mission control for everything that keeps us alive. Breathing, heart rate, all the basics. When that gets compressed, those systems shut down. That's what makes ICP so incredibly deadly. So what causes this pressure cooker to just go haywire? Well, it usually boils down to one of three things. First, you could have increased bleeding in the brain, maybe from a ruptured aneurysm or a bad stroke. Second, you could have massive swelling, what we call edema, maybe from a traumatic head injury or an infection like meningitis. Or third, you could literally have more stuff in the brain, like a growing tumor. Any of these add volume to a box that just can't stretch. Okay, now that we know what it is, let's talk about how to spot it, because recognizing the signs of ICP is truly a race against time. The earlier you catch it, the better the odds. And these signs, they progress from super subtle to catastrophically obvious, so knowing what to look for at each stage is absolutely key. You know, the signs of ICP don't just all show up at once. They follow this really dangerous timeline. It starts with the early signs, which can be kind of tricky to spot. Then it moves into the moderate signs, which are much more alarming. And finally, you get the late, deadly signs, which are basically the brain screaming for help. Now, if you take away only one thing from this entire explainer, please make it this right here. The absolute earliest, number one sign of increased ICP is an altered level of consciousness. And I'm not talking about a full-on coma. It could be something as subtle as the patient being newly irritable or restless or just off. This happens because the brain cells aren't getting the oxygen they need. It's the first red flag. Now, as that pressure continues to build, we get to the moderate signs. And a huge textbook priority finding is sudden projectile vomiting that happens without any nausea beforehand. They don't feel sick, they just vomit. If you see this, it is a massive warning sign, and you need to get the provider on the phone like yesterday. Okay, this is where things get really, really serious. The late-stage signs mean the pressure is so high that it is actively crushing the brainstem. These are the signs that tell you this is a code-level medical emergency. The body's last-ditch effort to save itself shows up as something called Cushing's triad. A great way to remember it is the crushing triad, because the brainstem is literally being crushed. Here's what you see. A super high blood pressure with what we call a widening pulse pressure. That means the top number and bottom number are getting further and further apart. But at the same time, the heart rate and respiratory rate get crushed down, becoming dangerously low and irregular. Another really terrifying late sign is abnormal posturing. With decorticate posturing, the arms and legs flex inward, toward the core of the body. But even worse, and I mean way worse, is decerebrate posturing. That's when the extremities extend and flex outward. This is a very, very grim sign of severe brain damage. And the list of deadly signs just keeps going. You'll see pupils that are fixed and blown wide open, maybe to 8 millimeters, a stiff neck, which we call nuchal rigidity, a positive Babinski's reflex in an adult, where their toes fan out instead of curling in, and of course, seizures, which can lead to a full-blown coma. And speaking of comas, we use something called the Glasgow Coma Scale, or GCS, to measure consciousness. 15 is a perfect score. But the critical number you have to remember is less than 8. If your patient's GCS score drops below 8, they are in a coma, and the absolute priority is to intubate and protect their airway. Less than 8, intubate. So, you've identified the signs. What do you actually do about it? This is where we get into the nursing playbook, the essential interventions you'll perform to manage this patient and hopefully stop things from getting any worse. A great way to remember this is the mnemonic ICPS. I is for mobilize the head, keep it in a neutral midline position. C is for CO2 low. See, high CO2 makes blood vessels in the brain dilate, which makes swelling worse, so we want to keep it low. P is for positioning, head of the bed up to 30 to 35 degrees, and absolutely no flexing of the neck, waist, or hips. And S is for suctioning, which we have to be so careful with. Let's really drill down on that suctioning point because it's a huge deal. Suctioning, while sometimes necessary, can cause a massive spike in ICP. So the rule is simple and non-negotiable. You suction for 10 seconds or less. That's it, no more. And you only do it when you absolutely have to. Patient and family education is also huge here. There are a bunch of things the patient absolutely cannot do because they will make that pressure skyrocket. This means no coughing, no sneezing, no blowing their nose, and no bearing down like they're having a bowel movement. That's the Valsalva maneuver. Basically, it's a no flex, no strain zone. All right, so we've covered our nursing interventions. Now let's talk about pharmacology. Because while our actions are critical, we also have some powerful medications we can use to directly fight that swelling and bring the pressure down. The number one go-to drug for increased ICP is Mannitol. It's a special type of diuretic called an osmotic diuretic, and the way it works is pretty cool. It basically makes the blood super concentrated, so it literally pulls excess fluid out of the swollen brain cells and dumps it back into the bloodstream so the kidneys can finally get rid of it. It's like wringing out a waterlogged sponge. But here is the massive catch, the Mannitol paradox that you have to know. By pulling all that fluid into the blood vessels so quickly, it can actually cause fluid volume overload before the kidneys have a chance to do their job. This can push a patient right into heart failure. So the most important thing to monitor for is signs of pulmonary edema, like new crackles in the lungs. A diuretic that can cause fluid overload? Wild, right? So after going through all of this, the causes, the crazy late-stage signs, the interventions, let's circle back to the very beginning. Let's end with one final question to lock it all in. Of all the signs we've talked about, from the posturing to the pupil changes, which one is the absolute first to show up? Which one is that initial whisper that gives you the earliest possible chance to jump in and save a life?